I'm Jan Mayer, and I've worked in the drug and alcohol field for somewhat over 30 years. I feel like I should say I'm a recovering drug and alcohol worker, but I'm not. I'm not in recovery, I'm stuck. And throughout that time, I've also had an interest in those people who present with not just drug and alcohol problems. I'll come back to that in a minute. So I first came on the Aberdeen course, the Mindfulness Association MSc, because there's loads of studies out internationally saying that particularly 8-week programs in mindfulness really help people who are trying to make a lasting change to their drug and alcohol use. There are very few in the UK. And the obvious one to go on would be a course that taught you about specifically working with drug and alcohol use. But remember, I had that interest in people who don't just have drug and alcohol problems. And also, right from the start, my biggest hunch was that what people who are some of the most stigmatised in our society need is compassion and the ability to get self-compassion. And that's what the Aberdeen course offers. During the course, I started to see real connections between the MBLC approach and an approach that's around in particularly mental health and coming in the drug and alcohol field, an emerging trend towards an asset-based community development approach, an approach that moves from asking what's wrong with you to what's happened to you. And actually that journey's gone on. It's gone on and on after I finished this dissertation, and so I'm going to give you a bit of the ending right at the beginning. And so where I've got to now is I'm not even convinced we should use the word recovery, because recovery implies there is something to be fixed. There is some kind of disorder, that there's something wrong with the person. And so the rest of the presentation, I do use the word recovery. And yet, I'd invite you to think about the fact that what the MBLC offers is this idea of a non-clinical approach that helps people to look at their own suffering in a different way and meet it in a different way, and maybe to connect to the common humanity and not need to be thinking of themselves as recovering from anything because they're already human beings doing a good job at living. So I said one rationale for this study is that there's lots of international studies saying that MBIs work for people who are trying to change the drug and alcohol use. There are very few in the UK, but even internationally, most of the studies into MBIs look at very precisely chosen cohorts of people who are only recovering from drug and alcohol use. And frankly, you know, I was doing a session which was called a dual diagnosis session for people who have mental health problems and substance misuse problems. And one of them said to me, you know, if you think I've only got 2 problems, you're really, really way out there. And most people don't have just drug and alcohol problems. So the studies are not really looking at the real world. And I wanted to look at the real world. So the study I did, and I'll tell you a little bit more about methodology in a minute, but it involved 2 cohorts. We started out with 24 people. There was a lot of dropout, and that's something we need to think about. And there were 2 cohorts. One was from a fairly affluent area, Sheffield, in an affluent suburb of Sheffield. It was a primary alcohol service, and it worked with people who were theoretically, at least the story they told themselves, or the service told itself, much further in this recovery journey than a lot of other services. So it was supposed to be at the far end of recovery, people who'd already signed up to abstinence, been abstinent for quite a long time. That was the group with the highest dropout. Only 2 people completed, and you'll notice they're the only people who only had in recovery from dependent substance use on their list. My other cohort, these people in the middle, were Keighley. Keighley is a very deprived area of West Yorkshire. It has many more problems. The service I was working with there was a drug and alcohol service, so there was people, everybody who came on the course had completed some kind of recovery programme for one substance that was their trigger substance. They were all either alcohol or heroin. It's pretty old-fashioned, Keith, they haven't found other drugs yet. You know, there's still all alcohol, you know, yeah, it's all alcohol or heroin still. They haven't found it. They haven't even discovered spice, you know, we're working. And what really struck me is that we actually had a lower dropout in this, even though theoretically they were much earlier in their journey. These people had all only been abstinent for 8 weeks. They'd just completed something called a structured recovery programme. And lots of them were also still using other substances rather than their prime one. And every single one of them had at least one mental health diagnosis or label. Actually, the vast majority had 2. The person in the middle there, well, one of the 2 people in the middle there, there's 2 in the middle there, had 4 different mental health diagnoses that she'd been slapped on by different people at a time. You can see that 3 of them were carers for people with other problems, with all the issues that Jackie's already raised about being carers. And 3 of them had severe physical health issues of their own. And you can see that we've got 2 people who have all of those issues. They're recovering from a substance use, they've stopped using a drug that they've used to survive for quite a long time. They're suffering with quite severe physical health problems where they've got a consultant in a hospital helping them with their physical health. They've got at least one mental health diagnosis, and they're struggling with looking after, in the case of the 2 I'm talking about in the middle, one of them was looking after her partner, a man who had very severe heart problems and couldn't get out of bed, and the other was caring for a mother who had multiple disabilities. So kind of complex stuff going on here. So what do we do? Well, the first thing I want to say about the methodology is it was designed by people from those 2 services involved in the studies. So there was a pilot first where I introduced the MBLC, we did the introductory sessions, and then I did focus groups and interviews to say, how would we even find out whether this would be useful to you? And so the methodology was co-produced. I come from a very scientific route, and I wanted to do a lovely, pure quantitative study. They wouldn't let me. So I ended up doing mixed methods, and whoops, let's go back. You can see that the 2 went in parallel, and a bit like other people have already said, what was really interesting, and they were right, is it was this synthesizing analysis that brings together the quantitative and qualitative that I learnt most from. And I think they learnt most from. So the quantitative bit was pre and post studies and the interviews, and then there was interviews at the end. And so the findings, the important finding was that self-compassion went up significantly in everybody. The next one along is a measure of recovery capital, and that went up but not significantly. What's really interesting is it went down in quite a lot of people because they were more honest about their use. What they said they liked was the structure, the fact that they could bring the whole of their issues together, the self-compassion, and the fact that they could now be honest. And what I want to leave you with, you don't even need to read it, what I want you to leave you with, the normal conclusion from this kind of thing is we need more research. We do. Please, 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 please donate to the Everyone Project so we can do more. That's my conclusion.